Hello, my name's Brian Lally. I'm a Penn medicine physician, and I'm also one of the radiation oncologists here at Doylestown Hospital. Today, I was going to talk to you about prostate SBRT, or they also call it stereotactic body radiotherapy or stereotactic ablative body radiotherapy. The concept is real simple. We're trying to use radiation as a scalpel to treat prostate cancer. Radiation is a drug. It's got a prescription with a dose and a frequency. When I prescribe Tylenol, I give it to patients in grams. When I prescribe saline, I give it to patient in liters. When I prescribe radiation, I prescribe it in gray, which is a measure of energy. Traditionally, what we would do up until about 10 years ago is prescribe about 80 gray at 1.8 gray per day over 44 treatments. A treatment is given Monday through Friday, holidays and weekends off. So this is about 9 weeks. Over the last 5-10 years, we started moving to doing what we call hypofractionation, where we give 70 gray at 2.5 gray per day over 28 treatments. And studies have shown these two treatments to be the same. We're now moving to an approach called stereotactic body radiotherapy, where in select patients, we are giving 40 gray, 8 gray per day in 5 treatments. We usually give them over 2 weeks every other day. The studies look comparable, but we don't have the head-to-head data between SBRT and hypofrac as we do between hypofrac and standard radiation therapy. But the results look to be very similar, and so we do offer it to some patients. There was some really interesting data that was presented at this past year's ASTRO meeting that I wanted to talk about briefly. At Memorial Sloan Kettering Cancer Center, they looked at some of their patients who received either standard radiation therapy to that 75, almost 80 gray dose, compared with stereotactic body radiotherapy where they got 40 gray. And at Sloan, what they do is post-treatment biopsies 2 to 3 years later. It's kind of like a standard procedure to measure like local failure rates. And what they found that, with patients who received IMRT, about half of them had residual cancer cells within the prostate. Nothing to do with outcomes, survival, things like that. Just did the biopsy show residual cancer. For SBRT, this dropped to 17%. So what they hypothesize is that with a greater ablative dose, you're more likely to sterilize the prostate with SBRT than you are with IMRT. Another interesting study that was presented at ASTRO was the MIRAGE study. Now, this study was interesting to me for a couple different reasons, but patients all received stereotactic ablative body radiotherapy. They received that 5-fraction approach. But in half the patients, they used CT for image guidance when they delivered treatment. The other half used MR guidance. But also, it should be noted that the patients who received the CT guided, they used 4 millimeter margins when they went to treat the prostate for their target volume. The MR guidance only used 2 millimeter margin. Now I'll explain the difference between MR and CT shortly. But not only was a difference in imaging, but also a difference in the margins. Regardless of what you look at, how this was structured, it's notable that the patients who had the smaller margins had less urinary side effects and less rectal side effects. So now I'm going to show you how we plan and then deliver treatment with radiation for prostate SBRT. And I'm going to first show you what the CT and the images look like that we're planning off of. And let me do a little bit first to show you what the anatomy is we're looking at. First off, the left is on the right and the right is on the left. This is the bladder, okay? Coming over the top of the bladder and down the back, you see right here is the rectum, right? These are the 2 hips. Right here, we're seeing the seminal vesicles, okay? And now we're beginning to see the prostate. Here is the left femur or hip joint or hip, and here's the right hip. As I mentioned, there's the rectum, there's the tailbone, and the white thing that we see right here is the spacor, or rectal spacor. What I can tell you is that when we use it, we're using one that we can see on CAT scan and also on MRI. A lot of places only use the one that you can see on MRI. When we treat the patients, we also put in gold seeds in the prostate that you see right here, there, and there's a third one coming up right there. Now let's look at how this, you can kind of see, let me turn a few things off here. As you can see here, and we're going to zoom in, right here is the prostate, okay? And it's hard to see where it ends and where the capsule begins. But when you look at it on MRI, you get a really good sense of what the anatomy is, because the MRI is better to see the soft tissues. And so that helps us to contour out the area that we think is prostate and separate it out from the other structures that are in the area, like some little fat or other stuff that's within the pelvis, or the muscles that hold the prostate in place. And so using that MRI is critical. Now, one of the problems you have with the prostate, and this may be a better way of showing it, is that depending on how full the bladder is or how full the rectum is or is not for both of those two, the prostate is like a beanbag. So it may be squished by one of these two in this direction, and as a result, it can squeeze out in this direction or that direction. And so for that reason, it's helpful to know exactly where the prostate is when we're going to treat it. And so by doing this approach, where we not just do the fiducials, but also have this spacer in place where we can see on CT, it's really helpful to do the image registration and then the planning, and also account for any movement in the prostate that may occur prior to we begin treatment, or when we deliver the treatment for each days that we do. Now, this is what it looks like when we go to deliver treatment. The first thing we do is we get plain x-rays to go find those 3 gold seeds. This is other seeds for other reasons, or other clips from some surgical procedure. But these are the 3 seeds that we're looking for. And then we kind of double check that and obtain a second set of films to make sure that we're spot on with those 3 seeds. And then we get what we call a cone beam CT. And this is the machine that we use has a CAT scan on the front end. And so this is the simulation CT that we did for planning purposes before we treated. This is that crude CAT scan that we get right before each treatment. And it's called the cone beam CT, as I mentioned, and it allows us to do a couple of things. First thing, we see the bladder, make sure it's around the same. We look for the rectum, make sure that is also around the same size. And with this spacer, let me take off some of these structures. I'm going to highlight the fiducials again, as well as the rectum. And you can see it right there. Now I'm going to highlight the spacer. And it's really helpful to, with just those 3 seeds, there may be some distortion of the prostate from the bladder or rectum, but by having that spacer in there, we really make sure that that's kept to a minimum. And so that way we're able to use those smaller margins. You know, MR or CT guidance is great for doing that. The machines that use only KV guidance can't do this. You know, things like a CyberKnife can't do this. But it's really helpful to see that and make sure that we're accurately treating the prostate. Just want to say thanks for your time today.